here. Oh, I'm tall enough. Well, hello, everyone. I am so pleased that you are here today. My name is Diane Hank, and I'm the Director of Culture Initiatives for... Not working well? I am. How's that? Should be. Let me put my glasses on so I can see the turn-on switch. How's this? Better? I'm still Diane Hank, and I'm still from the Office for People with Developmental Disabilities, and I'm still really glad that you are all here. Thank you for making the trek. Some of you, I know, had to deal with weather conditions. Some of the folks who were going to join us today are on the webcast instead because of weather conditions. So hopefully, web people, you are also out there, and we thank you for your participation. Let me just go over very, very briefly a couple of quick points before I hand over the podium to Courtney Burke. I wanted to explain basically the overview of what we'll be doing today. Let me grab the clicker. Over the next couple of hours, we will have several presentations. Here's our agenda. We'll begin with Courtney and then move on to Clarence Sundrum. Very appreciative to both of them for being here today. Then each of the four agencies will be doing a brief presentation, and each of them has invited someone to speak from the provider perspective, whether it be a state-operated or a nonprofit provider. We'll go through the four agency presentations, and then at that close, we'll open the discussion up for our forum. For the folks who are watching via the webcast, we don't have a way for you to speak into our web system. What we have is an email address. So if you are watching via the web online now, and any time during the presentation or during the Q&A portion you want to submit a question or a comment, we'd ask you to email that question or comment to forum@opwdd.ny.gov. And we have one of our work team colleagues, Laura Mandel from OMH, who's going to monitor that email box during the time we're together, and she will share those comments as we move through the presentations. Also, for our speakers today, I'm not going to get up in between each speaker and introduce. If you are one of our speakers on the agenda, I would simply ask that as you transition through, please identify yourself so folks will know who is speaking. We do have most of the names in the PowerPoint slides as well. But that way we can transition easily, and I won't have to get up and reintroduce people as we move through. Let's see if I've forgotten anything else. Oh, the last part. Much like the Academy Awards, we do have time frames to which we have to adhere. One of my other colleagues from our Restraint Reduction Work Group, Barb Staples, is in the back, and she has a very high-tech system. She will hold up a 2 or a 1. If you have 2 minutes left to your presentation, you will see the 2. And then, as the seconds tick away, you'll see the 1. After that, music will begin to play, and there'll be a hook. So I understand, though, there's so much that we want to cover today, and we understand that the allotted time for presentations is really quite brief, and we know that, but this is a first meeting, and we are trying to fit in as much as possible. So to the degree that you are able, please try to adhere to the time frames, and we'll try to be helpful with our high-tech sign in the back. So at this point, I'm going to turn the beginning of our forum over to Courtney Burke, our Deputy Secretary for Health, and I'll give you the clicker. There's just a few slides. And there we go.
Thank you. Thanks, Diane, and I do want to thank you for all the work you've done over the past year or so in helping organize this group together. So my special thanks to you, Diane. Also, thank you to the commissioners and other leadership that's here from the agencies, and for the staff within your agencies who have devoted time to this effort over the past year or so. Really appreciate all the efforts. I'm just going to give a very brief history as to why we're doing this today, where we are now, and what we hope to do today, and why we decided this was a good idea. This process began in late 2013. It was an interest of mine, having come from the Office for People with Developmental Disabilities. We noticed that oftentimes when we had a situation at a facility or a situation at a home where a restraint had to be used, that it was often tied to other factors that were related to quality of care. And so we started to focus in on how do we reduce restraints, because we would then see less incidents overall. What was it about the culture that the restraint had to be used in the first place? And I think we learned a lot from that experience. I think the things that I learned was, number one, to begin to address the issue. we had to have people who are interested in it in the agencies. And that's why it's very important that the leadership of the agencies is here today and has been supportive of this effort. But you also had to have the staff involved wanting to know why this was happening and have an interest in changing it. And we looked at a number of different ways as to how that could be done. We found a lot of differences between agencies where there was success with reducing restraints in certain situations or other ones where a lot of restraint was happening. So we tried to learn from that to begin to change some of our own practices. So the first thing I think really was having a common understanding among the agency that this was a priority and it was something that we wanted to focus on at all levels. So having the leadership there all the way down to the front lines. I think the second thing that we learned from that experience is that it was really important for us to have just information and data about where restraint was happening, why was it happening. And we began to notice patterns that began to tell us some of the answers to our questions. So we could focus our efforts on those places where there might be more use of restraints than others. I think another thing is that in order to reduce the restraint, we had to have tools, training, and staff that were willing to want to go towards the goal of reducing restraint. So a curriculum that had been in the works for some time was rolled out at the agency that very much focused on not how do we reduce, but how do we create a positive environment? Because if you create the positive environment first, you're likely to see less use of restraint. So we had the leadership, we had the goal and the buy-in, we had the tools and the training, the data and information. The last piece that we felt was really important was persistence. And I can tell you, having this effort go on now for a year, it does require a lot of persistence. The issue of restraint and reducing restraint has one that's been around for many years. And when we first convened this work group, people said, well, we've tried this before and it hasn't worked. You do have to be persistent and you do have to continually learn and adapt. And so I think our groups and the staff and your agencies have been persistent at trying to address this issue. So today, what we've asked them to do is we've learned a lot from each other over the past year. We've learned a lot from the agencies and how they collect data, what works for them, how we approach things differently. And I think it's been beneficial for all the agencies because they've been able to not only learn from each other, but kind of keep each other accountable as to where they are. And we asked them to develop work plans, and we are going to go through those work plans today. You'll see those presented by your staff here today. The work plans focus on the things I just mentioned, data and the importance of data in making sure that we know where restraint is happening so we can begin to identify why that would be and target our efforts. Sharing their analysis with programs as to why things are working or not working. Identifying outliers so that they can be targeted, and then again, sharing best practices. So we're thrilled that we have a number of agencies here today who have taken us up on this offer to share the best practices and be part of this learning community. We hope this is something that continues on after today, where we can be sharing what we've learned in our best practices. So before I go on, the last thing I wanted to do was just thank some other people who have been instrumental, aside from Diane, in keeping this going. In particular, Tom Harmon. I saw him out there earlier. Tom, are you still here? No, he's in the back row hiding. Tom has been very good at providing really in-kind advice and guidance for this process going forward. And the second person would be Clarence Sundrum, who I have the pleasure of introducing. Clarence, as many of you know, is a special advisor to the governor on vulnerable populations, and he was sort of our cheerleader all along, telling us that we would make progress if we just kept at it. So without further ado, Clarence Sundrum.
So, a 10-year-old kid in a special education class grew frustrated with his inability to perform the tasks that were being assigned to him in the classroom. So he became distracted. And as he became distracted, he began to disturb the other students who were working on the assignment in the classroom. The teacher tried to redirect this student, but the teacher's efforts failed. The student got agitated. He started wandering around the class, poking at other students. He knocked over a desk. And the aide in the classroom tried to intervene to stop this incident from progressing. He tried to pull this child to calm him down. The kid fell to the floor. His neck was pressed against the leg of the desk that had fallen over. His neck got compressed, and a minute later he was dead. There is an epidemic of tragedies like this that are occurring across the country, in schools, in children's residential facilities, in psychiatric hospitals, in developmental disabilities programs, in group homes, you name it, and these sorts of tragedies are occurring. Now, while death is an extreme outcome for these incidents, there are many hundreds, if not thousands, of these kinds of restraint episodes going on, which leave people suffering serious harm, both physical and emotional. And it's not just the people who get hurt, the residents of these facilities, but these are often extremely traumatic experiences for the staff as well. And I've run into staff people who tell me that the traumatic effects have lingered for years after they've been engaged in these sorts of episodes. Now, no one sets out to achieve these sorts of results. We are, after all of us engaged in the helping professions. We commit our lives to doing this work because we care about people. We care about vulnerable people. We want to do something to improve the quality of their lives. That's why we go to work every day. But yet, despite our best intentions, there is harm that occurs on all too frequent a basis. And so I welcome this very bold initiative that is being undertaken to confront the problems that are inherent in restraints and seclusion. And I applaud all of you for your engagement in this reform effort to transform the culture of human services that, in the guise of helping people, sometimes often inflicts serious and lasting harm upon the people we are trying to help. The people in this room, the agency commissioners, the provider agency leaders, the clinical staff, have the power to change this culture. And it may be one of the most important things that you do in your careers in human services. I worked for the first Governor Cuomo through his 3 terms, and one of the things that he said has stuck with me. He said that if you want people to absorb the lessons that you are trying to teach, it's important for you to keep repeating them over and over and over again. So in that spirit, and also partly because there is a slightly different audience, I'm going to repeat some of the things that I said when we met a year ago, when Courtney launched this initiative in this room. As she alluded to it, this is not the first time that the state of New York has confronted the challenge of trying to reduce the use of restraints. It's happened many, many times before. And the past efforts have usually foundered on the issue of complexity, because this is not a simple problem. And especially when you look across human service agencies that serve different populations, have different traditions, have different regulatory structures. Each of them has a different way of even defining the intervention that we're talking about. There is a history and a culture of deferring to clinical judgment. And clinicians in many of these programs rule in deciding what is acceptable and what isn't. There is a strong demand for deference to the autonomy of local facility management, who knows best how to meet the challenges of serving the people who've been entrusted to them. There's the imperative of managing challenging behavior. When there are multiple duties to multiple people, you have to keep everybody safe. There are different types of restraints, different methods of implementing them, and different protocols for training staff. And looming in the background is the fear of liability, whether it's for action or for inaction. All of these are real issues that one cannot gloss over, and they have proven to be real obstacles to prior reform efforts. The obstacles have been so formidable that at the end of the day, They have left us to continue to tolerate practices that we don't like, we don't approve of, and some of which violate international treaties on cruel and inhuman treatment of vulnerable people. Complexity takes us down many, many blind alleys. And so when we met a year ago, I suggested that what we need to do is to focus on simplicity as we move forward. Let's focus on the things we all agree on and that are simple. One of the things I dare say that everybody in this room and everybody who's listening on the web agrees to is that in every system, restraint is not a desirable intervention. It should be used as little as possible, and it should be the last resort to intervene. But the fact is that most systems and many providers really do not know whether the practice is actually consistent with this broadly stated policy on which there is wide agreement. By way of illustration, some of you may know that I chaired the Commission on Quality of Care for 20 years. And one of the things we did was to investigate deaths. And every year, we investigated a handful of cases where patients in psychiatric hospitals died during the course of restraint. Now, beyond looking at the issues of appropriate restraint technique and staff training, we also looked backwards into the chain of events and behaviors that led to the decision to restrain the patient. What we found was that the triggering event was often not a dramatic and dangerous behavior for which restraint was the last resort, but something much more mundane, which was allowed to spiral out of control until the restraint was determined to be necessary. For example, a dispute over whether a patient can have a cigarette break at the time that he or she wanted it rather than at the time the staff scheduled it. A dispute over whether a patient could have regular coffee rather than decaffeinated coffee. And these kinds of episodes really put life into the phrase, "I'm dying for a cigarette," or "dying for a cup of coffee," because that is exactly what happened. Similar things have happened in classrooms, in group homes, and other residential facilities. So we decided to find out how much restraint was actually going on in psychiatric hospitals. And we used a relatively simple process. We collected data on the rates of user restraints. We made some crude calculations about the rates of usage to permit us to compare practices among a wide array of public psychiatric hospitals, private hospitals, municipal hospitals, psychiatric wings in general hospitals, and so on. We surveyed psychiatric patients about their reactions to being restrained, which was an eye-opening education about the extent to which this one experience in a psychiatric hospital shaped patients' attitudes towards the mental health system at large and towards their willingness to accept voluntary treatment in the future. We ranked the facilities by their rates of usage, and we did something very unorthodox. We published the data so all the facilities in the state could see where they stood. The dramatic differences in the rates of usage of restraints among hospitals serving similar populations made everyone question, why was this occurring? And it encouraged learning between programs facing similar challenges. And surprisingly, it led to a significant reduction in the use of restraints, especially among those facilities that were high users. That's all it took, was putting the data out there so people could engage in some critical self-examination of what it is they were doing. What was significant is that the changes that they made to accomplish this goal was often not rocket science, but common sense. An example that has stuck in my mind was a children's psychiatric center that had a very high rate of usage of restraints. And it dramatically cut that incidence by instituting a revolutionary new practice at that facility. Most of the restraints were occurring in the evenings after dinner was over and while the children were being prepared for bed. And there was a lot of free time for those children. A child psychiatrist decided to institute the practice of serving cookies and milk and telling bedtime stories to the children in that facility. And the rates of restraint at that facility just plummeted. So there are 6 simple things that I think each of your agencies can do to reduce the rate of restraint. And I know that some of you have already made some very significant strides forward with these in the course of the last year. First is to collect data on the usage, especially on programs where you don't have any data about what their practices are. Second, analyze the data. Now, this does not have to be some complicated regression analysis, but could be something as simple as calculating the frequencies of use at these facilities and finding a basis for comparison among similar facilities. In the course of doing that, you can identify both the high users as a facility or the high use of restraints with particular individuals, which would prompt closer examination of whether the practices are really consistent with the policy that we all seem to agree on, that restraint should be a last resort. As importantly, identify the low users and try to see what they're doing right that you can catch them at, because there's powerful learning in that example. Publish the data among the facilities and invite discussion. This is a powerful and simple tool to change behavior. That came home to me again about 2 years ago when I was doing the study for the governor on abuse and neglect among our facilities in the state, and I was looking at policies and practices and laws governing abuse and neglect. And I put up a chart that looked like a traffic signal with reds, greens, and yellows, comparing the nature of the policies from one agency to the other. And you didn't really have to say much more to say we have an incoherent system of setting policy regarding abuse and neglect. I think the same kind of analysis could be used today with restraint and seclusion by stripping it down to its essentials. Set simple but realistic goals for restraint reduction. As Courtney said, assign a champion within your agency and empower that person to take the lead for your agency to implement restraint reduction strategies and practices. And then do it again. Do it again every year. This cannot be a one-time effort, because as I've looked at major reform efforts across the country, they all start with optimism and enthusiasm. That's the easy stuff. You get a rah-rah speech, you get somebody like Courtney to stand up here and tell you how important this is, and you leave here with a lot of energy. But a little bit later, reality sinks in, you realize this is really a hard task. It's difficult to do this work. And this being government, a year later, many of the people who started out with this effort have gone on to other things. And the people who come in behind them are wondering, what the heck are we doing and why? And that leads to resignation and resentment, because people think they've been put in a situation where they're being asked to do the impossible, there aren't any resources, the commissioner has moved on, somebody else has come in and has a totally different set of priorities, and there you are stuck with an assignment that's impossible to do. And that eventually leads to opposition and abandonment, which is what has happened many, many times in this state over the past. And finally, maybe you get a new champion that starts you all over again, which is, where I think we are. We are at this point, I think, in the morning after. And what's really important for all the commissioners in this room, for all the deputy commissioners, for all the people who've been assigned the responsibility for your agencies, for provider agency executives, you are the leaders who have got to empower your staff. You are the one who've got to continue to make this a priority and stick with it. If you don't stick with it, failure can be assured. If you do stick with it, the chances of transforming lives for people who've been entrusted to your custody are endless. Thank you very much.
Good afternoon. My name is Marcia Fazio from the Office of Mental Health. I'm a Deputy Commissioner for Quality Management. It's great to be here. I just wanted to talk a little bit about the histories. I only have 2 minutes, so I'm going to talk fast. OMH began the journey to reduce restraint and seclusion in 2007 with a 4-year SAMHSA grant, which we called the PARS grant, the Positive Alternatives to Restraint and Seclusion. The grant propelled us really as an organization into action. We coalesced leadership around the grant. We developed training and resources. We developed a statewide learning collaborative, work groups, webinars. We rewrote our regulations, which were geared more to prevention than they were prior. And then we presented some data on restraint and seclusion. We made that public. You know, as Clarence talked about the importance of making your data public, we put it on our website. Last year, when Courtney and Clarence convened the work group that we're currently in now, we took a look at our data fresh. You know, we said there's been a slight uptick in our trend, so we particularly focused on forensic facilities. And it's those facilities that are going to be talking to you today. Brian Belfie's here from Kirby, and Warren Scott is here from Mid-Hudson. The importance of focusing on the forensic facilities, we think, is because that is our most difficult population. We have our patients with the highest level of violence and clinically compelling histories that we have to deal with. We also have a culture that's very close to the correction system in terms of mindset, you know, more so than therapy, so it's a little more challenging. So we thought if we can do reduction of restraint and seclusion in our forensic facilities, we can do it anywhere. So I want to just, acknowledge the efforts that have been done so far for our forensic facilities. I want to thank Joe Freeburn, who's the Executive Director of Mid-Hudson, and Vinnie McCauley, who's the Executive Director at Kirby, for coming today, and the folks to show their support, because there are tremendous challenges that are facing our forensic facilities: census, overcrowding, you name it. They've got tons of things on the plate, and yet they remain committed to the goal of reducing restraint and seclusion. So I want to acknowledge their efforts. We also we're focusing now on 5 new programs, our RTFs, which are licensed voluntary programs for youth. We're looking at the trends, the data trends that show the highest outliers in our state. So the next part of our project will be to focus on reducing the rates in those facilities as well. So I did not go over my PowerPoint here, but the thing is, just to show you a little bit, I feel like I've been under that rock before. Just to show you the SAMHSA 6 core strategies. There's a link to that. I just want to highlight the importance of that training, and I think our folks will talk about that, really the gold standard. And I also want to talk about, the web page that we just started, where we took all the materials that we developed from the grant and we put them up here. So I think, Brian?
Thank you, Marcia. So I'm Brian Belfie. I'm a Deputy Director of Operations at Kirby Forensic Psychiatric Center. So for those of you who don't know, Kirby is a maximum security forensic psychiatric center located in New York City. We cater to individuals who were found incompetent to stand trial and those who were found insane at the time of their crime. The lion's share of our population that I'm focused on here today is the incompetent to stand trial individuals. So they come from Rikers Island. On a daily basis, we do about 250 to 275 admissions and discharge each year of these individuals. So about 80 to 90% of them come in with some significant psychotic or mood-related disorder. So it's pretty challenging psychiatrically to try to make sure that they're individuals that we can work with on a daily basis. Routinely, I get, correction officers coming up in the van with the inmates or the defendants at the time saying, "You sure you want me to take all the handcuffs off? You sure you want me to take the orange jumpsuit off?" And we say, "Yes, they're a patient now." So they come in the hospital. One of the anecdotes I always like to tell about our SHA staff who does God's work with these guys, are analogous to correction officers, is I was down in the admissions one day, and they had the shower running, and I was like, "Oh, is the admission here?" And they're like, "No, we're just warming up the shower for him," which I thought was very sweet, these types of little things that they do to try to keep our patients safe. So just focusing on the 6 core strategies as far as our institution and what we've done to try to reduce seclusion and restraint. for the last 10 years, we have not restrained anybody, believe it or not. Up until recently, a gift from Donna Hall, our Associate Commissioner, recently we got a patient who was incredibly challenging, and we've had to use restraint again, but we're working to make that better, Donna. So, but the leadership and we've really focused on is a campaign of education. So we realized that just drawing attention to reducing exclusion and restraint has made such a big difference in working with our patients, even just down to from meetings, from all the different complement of staff to our patient advisory committee. We've also done a couple of different research studies that focused on looking at risk factors associated with individuals who end up being violent. So we'd evaluate them with a battery of psychological tests as they came in, and we try to identify risk factors going forward for these individuals. And also in that battery was questions related to victimology and those who have experienced trauma. So we're very much focused on identifying these risk factors as early as possible and then trying to address them and then learning from that going forward. So in addition to, as we were talking about the data, obviously we're collecting data on an ongoing basis with the reduction of seclusion and restraint. We've implemented a Zen room. So in lieu of timeout, they go to this room where individuals kind of chill out. We've hired a number of different peer specialists that we think are very helpful in relating to our patient population. And as I said, we really studied when these seclusion and restraints happen, obviously focusing on seclusion. And most of our population, it happened right after they came in. So once we got them stabilized, they were okay, and they didn't have any kind of seclusions after that. So we've been very aggressive in light of this recent initiative to try to make this a priority within our facility. So I'm out of time. Thanks so much.
Okay, I'm Warren Scove from Mid-Hudson, and similar clientele that Brian just described, so I do not have to go over that, but our most challenging patients have been the 730 patients. They're the ones that come because of lack of competence issues, and a lot of the are coming from places like Rikers Island, and you know the cultural change from going from a jail setting to a hospital setting is quite extraordinary, quite a challenge, quite difficult. We implemented, and you do have a handout, so things that you missed and things that I can't go through, you'll have that there. But we actually implemented the 6 core strategies in 2005. Some of our leadership staff got trained, and we've been plugging away since. When we first started in 2004, we averaged like 1,000 hours of restraint a month. Now, over recent years, with all our efforts, we're to about 60 hours a month. Now what we're really trying to do is drill down. And that's what we've been focusing on very extensively the last year. So to do that, in February of 2014, we formulated a new work group called the Ward Structure Work Group, co-chaired by myself and the Director of Administration. We got a lot of direct care staff working with us, nursing staff, clinical staff, and have been plugging away ever since. Our 3 most challenging wards have been the 2 730 wards. Again, those are the competency cases, and our female service. That's really where the numbers were highest, so that is where we were implementing the most changes, and we were piloting things on one of the male wards, 3132, and then we would bring it over to other places. So I'm going to highlight in my limited time some of the things we've been doing over the past year to really try to get some further improvement. One thing is we've always had a privilege system, but the 730 patients just would not buy into it. It just did not motivate them. So we revamped the whole privileging system. We added things in, just to provide more incentive. You could stay up later, have more access to the phone to call home. You could do evening work skills and such. Thank you for that. You get increased allowance to spend in the canteen. And there was a movie night that we added with the large screen TV, and you could get snacks. And what would happen? You would have to maintain your silver card. We have a privilege system, so you have a silver card and you have basic level. So if you have your silver card, you have all these great things that can happen that you can take part in. And that really was pretty effective. One of the charts I gave you, we started tracking the data with the silver cards, and over a recent 3-month period, we were in an upward trend. Another thing that we did was another initiative, No Patient Left Behind. We're a hospital where you have to move to programming. We're not self-contained. It's almost like a college campus. You go here, you go there. And we were actually having trouble getting patients to move for different reasons. So we really made a concerted effort. We have close to 100% movement now unless somebody is sick. And that also has helped. You know, you're in programming, you're getting the treatment, and people are just much better when they're active. The last thing I'll talk about, and you have a handout on this, is positive action awards. And this came from the staff, the direct care staff themselves. It's just kind of it's a system where somebody can be rewarded for doing the right thing. You get a little slip that gives you a $1 credit toward canteen to spend money, and that's been going well. So I highlighted the data on 3132 for you. You have two graphs. It's been an upward trend over the past 18 months in the hours of restraint and just restraint in total there. And we are now incorporating this into our Six Sigma project. And probably a lot of people in this room know about Lean Six Sigma, just a way to methodically go about quality improvement. And the last point I make before I'm dragged off the stage is the gel effect. And this is just something that hit me recently. When you try to do a whole bunch of new things with your staff and with the patients, it really takes a while for it to gel. We've been at this for a bunch of months now, but to get everybody used to, we're not here to punish. It really pays to award people, recognize people, to provide people with motivation and incentive. It really works. But myself and other leadership people, we just in our management meetings, we just hammer away at how are these programs, how are we doing with them? And I know just something. And my last statement was I looked at the data from January to February, just got it, and we had 100 less incidents in February. I know it's 3 days shorter, but 100 less incidents in February than in January. And I'm hoping that's a trend that shows the gel effect is starting to take place, and we're using all these tools we've put into place. Thank you.
All right, good afternoon, everyone. Jill Pettinger, Assistant Deputy Commissioner with OPWDD. And we have introduced, as Courtney did reference, a number of quality improvement initiatives over the past several years. And these have really been focused on a goal of promoting and improving safeguards and protections for individuals' rights, improving health and safety, particularly where behavioral interventions are involved. For example, we promulgated our person-centered behavioral intervention regulations, which went a long ways towards establishing a common set of definitions and standards for clinical practice and expectations in the field, something that didn't really exist in any consistent way prior to that. We also developed and implemented our restrictive intervention application, which was our first effort to really have a method to collect data about what's happening with restrictive or intrusive behavioral practices out in the field. Again, we had clinical data that was gathered. Everything was sort of cataloged on an individual or program-specific level, but for the first time now, we have the ability to gather and look at data across the state from all of our state and voluntary operated programs. So having data is certainly a critical element to assuring that we're able to make additional quality improvement goals as we move forward. We've also have developed and begun implementing a number of workforce development initiatives because staff training is a critical component to improving the quality of our services and creating a culture of respect and in terms of how individuals are working with the folks that we support. And the other important thing that we started a number of years ago was really having very specific and frequent conversations with our senior leadership from our field offices as well as within the central office of our organization about restraint and the importance of restraint reduction, the importance of really looking at what's impacting the quality of our services and what's having positive or negative impacts upon service delivery and how those things are impacting our rates of restrictive or intrusive interventions. And really, senior leadership has to set the tone and the expectation for what happens in the field. I'm not in the field every day. Our directors are in the field and their staff throughout their chain of command really have to be on top of what's happening and really setting that tone and the cultural expectation on the ground level where direct services are being delivered by our staff. And of course, our direct support professionals are those individuals most often engaging with the individuals that we support. So it's critical that the culture, positive culture, starts from the top, but that it's disseminated across the organization. All right, we've accomplished over our time a number of we haven't had a number of accomplishments, and these have really been helpful on many levels, allowing us to identify and reinforce optimal or best practices and performance that is already happening, and we have some examples of that here with us today, as well as focusing in on areas where we need to make more improvements. For example, data is great to have. We're really excited that we now have RIA data, or restrictive intervention data, but we need to be sure that our data is reliable and valid before we can draw any meaningful conclusions from it. So to that end, we've been examining things like our null data, or where we have the absence of data being reported in, because we have to start looking at, does that mean no interventions are happening in these settings? If so, great. If not, what's the problem or deficit with the reporting? Also looking at timeliness of data entry. Critical to have timely data entered, because when we're drawing down reports in central office or at a regional leadership level, we need to make sure all the data is there so we can again draw meaningful conclusions from it. We also identified a data set that was missing. We were seeing, okay, some reductions in the use of restrictive or intrusive interventions, but perhaps some increases in the use of other interventions like the calling of 911 to respond to behavioral events in some of our community programs. Obviously, that's a critical element that we need to add to our data collection process, because we need to understand how that's impacting or perhaps changing the dynamic of how restraint might be happening now, but by a different source as opposed to our own staff. It's happening by first responders, things of that nature. So we're looking at all of those types of improvements. We also have several staff training initiatives underway. What I'm showing here quickly is a graph we are starting to look at in collaboration with our partner agencies, other state agencies, some methods for how we analyze our data. Again, we're new to having this data, so we talked to OCFS, we've talked to OMH. How do you guys analyze and portray your data so that it's in a simple, meaningful context, people can get it and understand it? We looked at our campus programs, just in this example here, and starting to establish a rate of restraint metric for care days for individuals in one of our campus-based facilities. Because again, similar to OMH, we have more utilization of restrictive interventions happening at our campus-based programs. We want to understand that better. So it's important to look at our data. Certainly for our community-operated programs as well, just another example of how our RIA data can be displayed to look at on a more individual-specific or case-specific level what's happening with a specific individual in a group home setting. How can we look at what day of the week or time of day might be impacting what's happening with restraint or restrictive intervention utilization? All of those things can be pulled now that we have data elements to draw from. So, and finally, before I introduce our agency that's presenting today, we have a number of next steps, all of them, of course, focused on continued reduction in the use of restrictive interventions, whether they be restrictive physical interventions, the use of PRN or emergency medications, timeout room use, things of that nature, and certainly our new metric focusing on making sure we're not overusing 911 calls for behavioral intervention. So that was very short and sweet. But I'd like to introduce now Lauren Milovic, Director of Day Services at Schoharie County ARC, and I'll pass it over to you.
I don't have anything. Great. Good afternoon. Thank you. I'm Lauren Milovic, and I do work at Schoharie ARC. I'm one of the directors there. I'm so excited to be here today. This is going to be my testimonial to talk about the power of positive supports to create opportunities that people desire. This is our vision at Schoharie ARC, and I want to say that with the leadership and guidance and passion of our Executive Director, Tony Alvarez, who is here also today, as well as the commitment of the leadership and ultimately the investment of every single member of our organization, we have made the journey away from restrictive physical interventions. So how did we do it? It took time. I'm going to say this several times over the course of the next couple minutes. It started with this commitment, and in 2007, Tony shared his passion and determination with the Board of Directors to resolve to ultimately reduce and eliminate restrictive physical interventions over time. It continued with a champion. We've talked about a champion a couple times. Chuck Starks was our champion. He was a retired psychologist from OPWDD, and he was hired to lead the charge in our organization. His patience and untiring persistence to stay the course was instrumental in guiding and teaching the staff and the leaders in our organizations that there were alternatives and that they had the skills to support people in a caring and trusting and compassionate manner. It took some more time. It took a community. And in 2008 and 2009, little by little, this took several years, restrictive and punitive interventions were eliminated from over 80 formal behavior support programs and replaced by things like lifestyle enhancements, environmental modifications, and teaching strategies that reinforce the hopes and the dreams and the desires of the people that we serve. It took some more time. We introduced a curriculum, and in 2010, Creating Opportunities for Positive Relations was introduced to replace SKIP-R, incorporating the best of the available materials from a variety of resources, including Delaware ARC's Shift Happens and OPWDD's SKIP-R. The new curriculum emphasizes creating relationships, fostering those relationships, and teaching replacement behaviors and skills. In the first session, and in each session thereafter, Tony, in his role as executive director / teacher, shared his experience at Willowbrook when he was screening people there for deinstitutionalization in the years following the consent decree. And for me, this explained it all, because after more than 22 years of working with him and for him, I finally understood why it was so important to him that our organization provide not only a life in the community, but a life that empowered people to control their decisions, to make friends, to be treated with dignity and respect, and ultimately be free from restraint, isolation, abuse, and neglect. Sadly, though, even though Willowbrook closed several decades ago, we continue to support young people who are entering the world of adult services with similar histories of abuse, restraint, and neglect as a result of their educational and their residential experiences. So the gathering of this group today is just wonderful. It's a wonderful opportunity, and I hope it does continue to move forward. During Creating Opportunities, our staff learned to stop saying no to the people that we support. They learned to give people an alternative to that undesirable behavior and to teach them the skills that they would need to engage in that desirable behavior. It has changed our culture. Due in part to the turnover in the workforce at the voluntary nonprofit human service world, the majority of our current direct support professionals have never heard of SKIP. They don't know what it would be like to put their hands on somebody, and they can't imagine what it would be like at this point. And the nice thing is that they are able to engage people. They are teaching people, and quite often they have a lot of fun. Today, some of the experienced workforce members who said it would never ever work in our agency are some of our strongest champions. Chuck Starks has at this point retired completely from our work. So our veterans are our biggest champions at this point, and they have embraced the philosophy because they've seen how people can learn and grow and become happy. It takes time. I'm saying this over and over. It changes lives. During 2013 and 2014, co-facilitator Terry Tetlek and I have had the great pleasure of working with various organizations throughout the state and provider agencies and conferences, and we've been able to talk about our experience as an organization. It's been a wonderful privilege. Between 2010 and 2013, our rates of allegations of abuse, workman's compensation, and accidents and injuries to both staff and the people we serve have plummeted. And we've learned some lessons along the way. Keep it simple. Stop saying no. Number 2, teach people what you want them to do instead of telling them what they shouldn't do. Number 3, we are not hands-off. We do use physical prompting and support to teach people. Number 4, we do not use consequences. We teach people about outcomes. Number 5, we don't focus on what if. We focus on how can we. And the onus of responsibility is usually on us when something goes wrong. And it creates opportunities. And last and not least, I'll have two things to say. In 2015, we celebrate our 50th anniversary as an organization at Schoharie ARC, and we are also very, very proud to recognize that we are celebrating 5 years without restraints, helping people to lead richer lives and creating opportunities that people desire. So we thank you for inviting us here today and providing this opportunity to speak with you. Please don't hesitate to contact us. Tony has more information about the timeline that's attached to the agenda for today, and we can talk about some of the statistics that we do have information about, and this is a wonderful opportunity. Keep up the good work.
Hi, I'm David Bach. I'm with OCFS. I'm the Director of Quality Assurance within DJJOI. I tend to speak fast, so I should be able to get through our slides just fine. So OCFS has two divisions that have oversight over programs where youth are kept outside of their homes. Child Welfare and DJJOI. Child Welfare has oversight of 84 voluntary agencies, and DJJOI currently operates 12 New York State operated facilities throughout the state. We use different techniques for engaging youth and staff, and different techniques for physical restraint across both parts of the agency. However, they really key in on the core piece, which I've heard a lot of the presenters talk about, engagement. You really need to engage the population that you're working with in order to move toward any type of progress. And as that level of engagement improves and increases, obviously, so you have a negative correlation when it comes to restraints. The restraints tend to go down as engagement increases. So whether or not you're using TCI or SCM on the child welfare side, or using the New York model on the DJJOI side, it really keys in on engagement. And the presenter after me will get further into the New York model. The link between the engagement and when you do have to use a physical intervention, and physical interventions on both child welfare and the juvenile justice side are the last resort. These are when there's truly a safety concern at hand and there's no other option but to engage in a physical intervention. On the DJJOI side, we use something called the Individual Intervention Plan, the IIP, and that identifies a continuum of non-physical interventions that should be used prior to any type of physical intervention, and it's individualized to each youth that's in our facilities. Then on top of that, the physical interventions that are allowed for each youth are also identified on this tool. The biggest thing that we all need to know in dealing with vulnerable populations is you have to understand what type of intervention levels you're looking at. What's the data? How much restraint are we using, or little restraint are we using? You really need to have accurate, consistent data in order to make informed decisions. OCFS is committed to data-informed decision-making. We're committed to making sure that the data that we present is accurate and consistent. So it's a lot easier, as many of you would know, to gather, manage, and monitor data and systems from state-operated facilities than it is to work with the voluntaries and make sure that a network across the state is providing accurate data. So we started with DJJOI facilities because they're state-operated. I would say about a year and a half ago, we used the ARTS, which is the Automated Restraint Tracking System, very similar to RIA, and it captures all elements of a restraint that you could imagine. But about a year and a half ago, we said, well, we have a lot of data in there. What can we do with it? And how do we make it so it's usable for the end user, the directors of the facility, and the staff that are in there? So we created a monthly restraint report. This report goes out to every facility in the state so they can compare against themselves and compare against the other facilities that are in their grouping. So it's hard to see, but there's two lines. There's a blue line and a brown line. The blue line is a monthly rate based on 100 care days. And I don't have time to go into that, but it allows us to normalize population. So if we have a facility of 10, it's comparable to a facility with 100 in it, individuals. So that's the blue line. That plots out every single month the rate of restraint. The brown line, which is hard to see, is an annual moving average. So that allows for the facilities to measure against where they were a year ago on average to that day. And the red, yellow, and the green are thresholds that we developed with research in order to say what we think is an acceptable level of restraint. So those thresholds correspond to different degrees of actions that we request. So if a facility moves up into the yellow and maintains that level for 3 months, then we would expect a significant corrective action plan. If they move to the red, then necessarily they would have corrective action at the local level, but also at the home office level. And I'm getting the gaffe in a second, so I have to move on. So for next steps, child welfare is now looking at this and trying to adopt some of the models and the reports that we run in DJJOI. The important thing for them is getting all the voluntary agencies to provide accurate, consistent data. So by the fall, or by the spring of 2015, through the hard work of Rick Charbonneau, who's in the group somewhere over here, they plan on going live and being able to provide more reports for the voluntary agencies to take advantage of. DJJOI, we're continuing to just monitor our process and to make sure that we're always moving toward reducing restraints, where appropriate. And under the direction of our Deputy Commissioner Inez Nieves, I'm sure we're going to be very confident in our ability to move that forward and to make progress. And under the direction of our next speaker, who I have the privilege of introducing, Dr. Joe Tomasone. He's the principal author of the New York Model and a close colleague of mine. Joe?
So this is what happens when restraint reduction meets speed dating, I guess. A lot of my comments are conceptual. I really appreciate all the details that people have been able to give about their programs, and it's really validating to hear, because some of my comments are probably going to be repetitive to what you've already heard, but it's really validating to hear that like-minded, well-intentioned, intelligent, hardworking folks come to the same conclusions. So we sat down to look at restraint reduction in our system, and we very quickly realized that we had to make broad and systemic changes to our system. It wasn't just going to be as simple as changing rules or policies or procedures. It really had to be much broader than that. We had to change how people understood the youth that are in our care, how they understand, how they work with each other, and how they understand themselves and their roles. We really had to change how they think about the jobs that they do. A lot of our folks historically thought of themselves as people who turn keys, move kids from one program area to another program area. They didn't understand the power of their capacity to relate to kids and the incredible value of them being an agent of change, and that everybody can be an agent of change, whether you're the cook or the maintenance person or a direct care staff or a clinician or an administrator. Every interaction with a youth or a family member in our care creates an opportunity for a positive outcome. We really wanted to make sure that people understood that. The other theme that we hit on, that I heard other people hit on, is the idea of changing culture, because no matter how much training you do, we all realize that whether it's agency culture or facility culture, culture is a way more powerful shaper of behavior than training is. So you can do annual training year after year after year, and you'll find that you still have pockets of things that are going a certain way, and that's because that's the culture there, and you really have to change the culture. The other theme that I think is really important that other folks have talked about is the creation of community and a sense of community, that people are in it together, they have to rely on each other, they have to depend on each other, and if they're not able to do that, they're not going to be able to do some of the things that I'm going to talk about in a second in terms of feeling safe. And people aren't going to change unless they feel safe. Kids aren't going to be able to change, family members aren't going to be able to change, staff aren't going to be able to change unless they feel safe. So certainly the issue of trauma is very important. Our population has been reduced dramatically, and what we find as a result of that we have way more kids with mental health issues, substance abuse issues, and a history of trauma, and those are very complicated issues to deal with. What we also recognize, and is really important, is that we say over and over and over again, what's good in our system for youth and families, the new processes, the new procedures, the new techniques that we're using are good for our staff. It has to be win-win. It can't be we're just doing this for the kids and the family. It has to be we're doing it for everybody in the community in which we work. So let me give you 3 quick fundamental concepts of the New York model. The first is safety. It sounds trite and obvious. Thank you. But people aren't going to be able to change and try new things unless they feel safe. Again, a young person who's dysregulated, who you're asking to try something new that's never maybe worked for them or they've never tried before, isn't going to be able to try a new skill unless they feel safe. A staff member who you're asking to interact with differently with a young person isn't going to be able to try that skill unless they feel safe, and they feel like they're not going to be blamed or punished if it doesn't go perfectly well the first time or even the second time or even the third time. So again, we have a real strong principle of being non-judgmental. When somebody's having a problem, we assume that they're doing the best they can and that we want to be able to help them do better. If we start with that approach, then you automatically extend a helping hand. If you assume bad action, if you assume somebody's doing something because they're just having a bad day or just want to do it, then that's blaming and shaming, and then that leads you down a bad path in terms of intervention. So safety. We also broaden that concept to include emotional, psychological, and physical safety. Second is skills. In order to create that safety, people have to have new skill sets. The kids and the families that we work with have to have new ways of doing things, and our staff have to have new ways of doing things. So we do a lot of training. It's certainly part and parcel of our program. And then we teach and reinforce, and that's something, I heard from other folks, very reinforcing positive skills to displace or replace problem skills or skills that are ineffective. So it's a very simple notion that thankfully a lot of folks have come to the same conclusions, but it's also part of our New York model. And then the most important concept, and Dave mentioned this, is engagement, that we really have to be connected to each other. Our system a decade ago was one of really clear silos. So you had some clinical folks who did treatment, and they were in one silo. You had education folks who did the teaching, and they were in another silo. You had our direct care staff, and they were in another silo, and we didn't share. We didn't talk to each other. We didn't back each other up. And so now our system is really one where it really strives and works every single day to create community, because if we can't rely on each other, we're not going to get anywhere. It's the only way to do this successfully is to have a community and to be able to rely on each other and feel like somebody's got your back. So those are three fundamental concepts of the New York model, which, again, sorry that we're in this format, but appreciate the time and the opportunity to speak. Thanks.
So good afternoon. My name is Pat Geary, and I'm with the Office of Special Education at the State Education Department. And I thank you for the opportunity to speak this afternoon. We have at State Ed placed a targeted focus on increasing positive behavioral supports in all of our schools for many, many years. On this initiative, we know that we have to, like many of the other presenters, as you go to reduce restraints, you have to increase the capacity of the school to deal with challenging behaviors in a constructive and positive way. And that is the focus of the work that we are doing throughout the department, not just in the Office of Special Education. We oversee many, many schools. We have, our office probably oversees about 1,200 schools that serve students with disabilities, and between public schools and BOCES and our approved private schools and our preschool programs and our charter schools. So we do rely on our policies. Back in 2007, we strengthened our behavioral intervention policies to very clearly prohibit certain types of actions. We prohibit any type of aversive interventions. And very powerful message we delivered at the time was a planned restraint, physical restraint for a student is a aversive intervention. And that was a mind shift and continues to be a mind shift for many of our schools, because if you can't do that, what do you do? And so it's led to the conversation about, now how do we improve this practice? We also set some very strict rules around other types of behavioral interventions, and including limiting the use of physical restraints and other types of emergency interventions, but clearly labeling these as emergency interventions, meaning everything else has to have been tried first. So we do rely on these regulations, and it began then to set the conversation about how can we help schools now build this capacity. We have invested significant amount of resources in our systems of positive behavioral supports. We have regional behavior specialists across the state. Back in 2012, I think it was, we started with about 15. A couple years ago, we increased them to 30. We recently added 10 more, so we now have 40 behavior specialists that the state funds, and they provide no-cost technical assistance to our schools to improve their behavioral practices. We also have a state-funded technical assistance center on positive behavioral interventions and supports. There are webinars, there's extensive resources. So we're putting out as many supports and capacity building partners as we can to the many entities that work with our students with disabilities. We also have some written tools that are guides. One is a guide for positive behavioral supports and interventions that gives research-based practices and links for many specific tools and strategies that effectively teach replacement behaviors. We know schools have to be very, very intentional with the work that they do to put school-wide, classroom-based, small group, and individualized supports in place for students with disabilities. So that's where we've really put most of our efforts. Data collection is somewhat of a challenge for us. Back in 2009, we did some data collection with our residential schools. We had 100% participation. And as a result, we were able to target technical assistance resources to some schools, conduct focus reviews, get them to work with us to take a look at practices, and have seen significant changes in practices. We are going back out this spring with another data collection tool for these same residential schools to continue that work and continue this targeting of our resources. We'll continue to work with the other agencies. We know we are sister agencies with all of our residential schools in particular, and so we need to work hand in hand in how they're addressing this and we're addressing this. And so now I'll introduce Ray Rayevsky from Hawthorne Cedar Knolls.
Good afternoon. My name is Ray Rayevsky. I'm the principal at Hawthorne Cedar Knolls, one of the principals in the 3 buildings. We are a special act school district. Our students come to us because they've struggled in traditional school settings, alternative school settings. They're placed through OMH, OCFS, Committee on Special Education. When I was asked to do this, I thought about 5 simple things that I work with my staff on when talking about reduction of restraints. And I think one common theme that I've heard is we've talked about creating a culture and a community that's strength-based. I said the use of restraints should only be used for safety reasons. When a child is endangering themselves, another client or student or a staff member, that should be the only reason that we would implement a restraint or seclusion. Restraints and seclusion should never be consequence-based. Number 2 was always a last resort. Exhaust all other options prior to the implementation of a restraint or seclusion. De-escalating students, clients with the least amount of resistance, identifying triggers and removing those triggers. Do not personalize students' or clients' behavior. It's not about us. It's not about the staff. It's about the child. Avoid power struggles. Again, avoid power struggles when kids are struggling in school or in the agency. And we often have this thing that we use, it's called a walk and talk. It's trying to get kids to sort of go for a walk, go with you, talk about what's going on, giving them open space to sort of express themselves. Something that goes hand in hand with that is number 3, understanding your students and clients. It is a key factor that everyone that works with that students understands that child's diagnosis, understands that child's challenges, trauma, and knowing strategies that student responds to. and using those. Different kids within our program respond to different strategies. They respond to different people. One kid may be comfortable going for a walk and talk. Another may want to go into a room and throw a ball. It's giving kids options and finding different strategies to support that child. For example, we often deal with the oppositional defiant child. Well, I can tell you if I tell them to go up, they're going to go down. If I say left, they're going to go right. It's knowing that child and then giving them options and setting 3 options for that child to decide. And most of the time, 99% of the time, that child chooses the right option. Identifying staff and clients that work well together. That when a kid responds well to a certain staff member, having that person on hand to respond. Putting that in a plan to support that child, and making clients feel safe. Again, number one thing is when children feel safe, they de-escalate a lot quicker. Number 4 is our positive behavior intervention and supports. It's strength-based. Focusing on the strength of that child. When a kid's having a difficult time, talking about the success they've had in school or in the program. It may be small steps, but focusing on those small steps to reinforce the success the kid had in the program, to make them feel like they're doing well and help them get out of whatever they're going through at that moment. Staff training, creating a common language, a community language where when we're responding to kids that are struggling, everyone uses the same words, therapeutic words that support that child in that moment. And the last is incident review team. Again, reviewing your incidents and looking at trends, where incidents happen, transition times, lunchtime, evenings, looking at, the child themselves. Do they need additional supports other than the PBIS and the positive systems you have put in place? And again, I think we're all here with one thing is to find different strategies on how we support children when they're struggling, whether it's in school, and reducing the number of physical interventions and restraints. Thank you.
Well, thank you to all of the speakers who have shared with us today, and a special thank you because we kept very close to all of our time frames, and I know that was hard because any one of the organizations or agencies here could have taken up the hour or two just to talk about things in depth that are going on. One thing that I've learned as a facilitator for the state work group is that we had to immediately acknowledge that we are all in very different places and that we're never going to be alike. We realized when we first sat down and looked at all of our regulations and policies that none of them matched. They have similar themes within them, and our goals, obviously, as Clarence stated, are to provide the best services that we can because we are in the business of serving people. But we didn't want to focus a great deal of time on our differences. Instead, we wanted to focus on individual work plans for each agency that we could pursue, ways that we could work together, areas in which we could collaborate, areas and ways in which we could hold each other accountable. OCFS, for instance, has been very, very helpful to us at our agency as Jill and the rest of the team has worked on our data issues because our data system is quite young, and we're still trying to work out a lot of the kinks in that system. So, as we thought further as a work group of what is our next step, we realized that as agencies, we have to continue to work on our work plans. Those are all different. We all have different data, different practices, as I said. But we wanted to reach out to our provider communities to ask them not only to engage with us, but to help advise us. So that's why we invited you here today. And at any point, Clarence, Courtney, please jump in. There are microphones that we have set up here in the front, and we have 2 microphones which some of our Excelsior and Empire Fellows are going to help with. This portion of our meeting is to hear from you. We have some ideas. We thought perhaps we could try to set the groundwork for a compact or a learning collaborative cross systems, imagine that, where our providers would engage, commit to also working on this issue with us. If you are in a position such as Schoharie, where you've been working on this for years, and you have some practices that you could share with other agencies, great. Or if you're an agency that has not had the time or resources to focus on this issue, perhaps we could help in that area. Before we got too far down the road on what sort of function or structure we should put in place to pull providers together, we thought it would be wisest to bring some providers together to hear from them. And that's really why you're here today. So for the next half hour or so, we'd like your questions, your comments, observations on our idea. What can we do together as providers in New York State, among many systems, to share and learn and move the dial? Because if we focus on it, we can change it. And our goal is, as Clarence also said, it's never that we want to use restraints. One thing we are all in agreement on is that we only want to use them when absolutely necessary. So, as I mentioned, there's a microphone on this side, which we will hand to you. There's a microphone on this side, which we will also bring to you. For folks that are on the web, if you want to make a comment or send a question, you can send it to forum@opwdd.ny.gov. I think I have it. Yeah, there we are. And Laura will read that question to us. One of the ideas that we are pursuing is perhaps trying to pursue some grant funding that would allow us to put a little bit more structure on this, because certainly a learning collaborative or a compact doesn't happen by itself, and we need to put some structure on that. But that's a little bit in the future at this point. We're hoping to pursue it in the short term. But again, before we got down that road, we wanted to know, what do you think we could do together? And what would you be willing to do or contribute to that end? So now I'm going to turn the tables, and the microphone is for you. Is there anyone who'd be willing to share something for our discussion? Don't be shy. What do you think of the idea of a learning collaborative? Anybody like it? I got one yes. What do you like about that idea?
Well, I think it's important that we all come together, because so many of our facilities, I work for Northern Rivers, so I have one school program that is just OCFS and the other one that is OMH and OCFS and SCD. And oftentimes the procedures, it's very confusing for your staff. And we're in our 4th year of PBIS, which has absolutely reduced our numbers by probably 90% and created that culture, which, you know, I've been there 30 years. I thought we already had the culture, but data doesn't lie. So I think it's important to continue. I think all the speakers had a common theme about the importance of a relationship with children, using data to inform your staff and train your staff, to look at where incidents occur. One gentleman talked about the importance of the residential facility, the intake coordinator, and the educational program, and the family and the court systems to work together. That's critical in meeting the needs of the kid, because it's not just an educational child or a residential child. So I think there would be some benefit, because all 4 of the presentations had common themes. In the educational world, we're heavy on PBIS, and we've been provided a tremendous amount of support from SCD, and we've taken advantage of it, where we've had them come in 3 times a week, and it helps. But so I do think there's certainly a advantage to bringing the 4 systems together.
May I ask you again, and I'm sorry, the issue with the microphones in the room, you're probably thinking, gee, I couldn't hear all that well. We have 2 sets of microphones for this production, and one has to do with the webcast. So folks on the web heard you perfectly. For those of us in the room, it was a little bit harder. So I don't want to make it frustrating for folks. So when you're speaking in the room, and even though you're speaking into a microphone, which is essential, please also speak very loudly so that folks in the room can hear. And what organization were you with again? I'm sorry, I didn't hear you when you first started out. Northern Rivers, okay.
One last podium we'll have, since we have our New York State SCD representatives. I have an enormous amount of staff that I have put in place to make that initiative go through with PBIS. Right next to me is Brenda Hacker, who's been a godsend in the implementation, but I have at least 3 or 4 people dedicated in a school of only 154 students. So you do have to find the resources. I've been able to use IDA and Title I money to do that, but you really have to have that infrastructure. To have someone running it for you and collecting the data and putting it back out into your staff and to take the time to work with your staff. For instance, we look at it weekly, and you'll find out that a teacher has a high amount of truancies or out of programs or a restraint. Hopefully not. We have very few. But it gives you an indication to go in proactively and work with that group of people. But it does take staffing.
As Chris said, I'm Brenda Hacker with Northeast Parent and Child Society. I would completely agree with the speakers that said it takes time and keep chipping away. Just chip away, chip away, chip away. It takes culture change, and if the leaders get behind it in the program, it won't happen overnight. So don't get frustrated. It's just something that we keep talking to staff about. We have wonderful individuals that rise to the occasion, and we get behind them. And if we have people who are sort of not on board, we don't give them the platform. This is how we do things. And it's a program that's been in existence for a very long time. And we have staff that have been there for 27 years, 23 years. I don't know our longest person, but there's not a lot of turnover. So the culture shift was challenging. And we're chipping away, we're planting seeds, we're supporting we have a lot of the staff that are creative and engaged, and they've got it, and we're just supporting them.
Over here, there's a microphone coming. It was Letitia here has got very high tech, but also speak loudly, please.
Is it turned on?
For the web people, as I said, they can hear you perfectly. But
my name's Nancy Seller, and I'm the Senior Vice President for Education Services at Upstate Cerebral Palsy in Utica. In 2008, we made a unilateral decision to close our timeout rooms. It was terrifying and abrupt, and it worked. We saw our workers' comp, our employee injuries, our student injuries plummet. It's made all the difference. Persistence certainly is the key. We have to keep talking about it. We have to keep reminding people. We also have DSP turnover. We have to retrain. But what I really want to comment about is the idea of the systems compact, the cross-systems compact. There could be no better solution for all of us. As we look at our programs and the things that we need, I'm often frustrated. Oh, I wish I had more mental health support. I wish I had this. I wish there was a better way to understand across agencies what the expectations are. If there were an opportunity for a group to come together to focus on the future and focus on positive things that we can do together, and then we can understand better and support one another better, Utica Upstate Cerebral Palsy's in. Thank you.
Thank you so much. I have seen a presentation on the outcomes from your decision in 2008, and it is remarkable, really remarkable. I will always remember. That data was amazing. So a smart move.
Hi, I'm Debbie Napolitano, and I'm here representing Hillside Children's Center. But I also wear many hats, including past president of the New York State Association for Behavior Analysis. So in all my hats, I'm thinking about the wonderful presentations. I want to make a comment just based on the work at Hillside that at least from my experiences across several of the systems that were represented here today, things are not that far apart in some key areas, and we've been able to bridge the system gap across several of those systems in the development of our support systems and our the way that we're looking to support kids with the greatest challenges. It's just a matter of really looking at how that works within our education programs, which often sit on the same campus as our OCFS programs, which sit on the same campus as our OPWD programs, and how can we be consistent across, because the key, as people are talking about, is really about teaching and teaching our staff and teaching the youth and the individuals that we're there to support, and how to build those relationships, how to increase engagement and replace the challenging behavior to get the things that are important to them, their needs met. And so, that's, I just wanted to point that out, that I don't think we're always that far apart between the systems, and there are ways to bridge those. The other is just a plug for, a lot of what I'm hearing are really things that behavior analysts do every day, of the needs and the things that people are describing that are working. Most people aren't aware that PBIS is actually a behavior analytics system, and so, I just want to just ask people to think about behavior analysis as one of the tools that may be very useful in this process.
Good afternoon. My name is Bill Gutman from St. Catherine's. I would like to endorse the Learning Collaborative. I think it's a great idea. I'd like to add an additional task to this work group. We need to make sure, back to Clarence's point, that we're getting the right workforce into our agencies. And part of this is what are the skills, competencies, reward, and what attracts the young people who come into our systems. Because if we get the right people with the right culture, we can make a change. But part of this is an old-fashioned human resources conversation between the agencies at the state level and the local level. So it's beyond just the direct care workforce or the teachers, but it's how do we get the right people in the door.
Thank you. Great comment on our workforce. We have a question on this side, so we'll take one over on this side, too.
Not so much a question as much as a comment.
I'm sorry, go ahead.
That's okay. My name is Matt Storiali. I am the CEO for YAI. We provide a variety of supports for people with developmental disabilities and serve children across the life cycle, from education programs to adult programs as well. I thought this was great today for a couple of different reasons. I think the mission or the vision of minimizing the use of physical interventions is critical. I think that one of the things we've always looked at YAI when we did the training as it relates to SKIP, or as we're preparing people around the promote, is physical intervention is the last resort. You only use it when you absolutely have to. And listening to some of the presentations today, a lot of that is being taken on. I love the fact that we're getting metrics. I think that this is incredible, because I think that sometimes, as you talk about a culture change, when you talk to people about the need to reduce the utilization of physical interventions, people already start to panic about, well, how am I going to handle this? It does take time, but I think that having data that can be evaluated, while at the same time having people at the front lines dealing with it with other people analyzing it as well, can allow for a lot of collaborative information sharing and also developing some strategic partnerships. I think the other thing that's really important that I heard today, safety is critical. Understanding the trauma that the individuals we support may have experienced, the issue of engagement for the individuals as well as the staff or families we're working with, and also keeping in mind the environment where these things may be occurring or you're trying to prevent them from occurring. I think that those are a lot of different things that there's a lot of energy from the people that presented today, and the cross-system check can really only make us better at what we do. And culture shift, it does take time, but just over the last year and a half, going through the experience of CQL and POMS and doing a culture shift about how we engage our individuals and listening to what they want, it does work, and you do see progress. So this is great. I think more and more providers as well as other partners getting involved will be very good.
Wonderful. Thanks. So we'll pass the mic further. One of the things I can say is, go ahead, Lahisha, get it. About the UCP presentation that I saw some years ago when Courtney was still at OPW, it was the data. When you see the numbers, and that's what I remember the most, frankly, is I remember all those slides of the data. When you saw the reductions they had in workers' compensation, injury to staff, and in the people that they were supporting, it didn't lie. It was dramatic. And so from even an administrative point of view, it was like, why wouldn't we do this? Right? Because if only for that, not to mention it's the right thing to do. So yes, over here on this side.
Hi, I'm Stephanie Orlando, and I'm not a provider. I am the executive director and a founder of Youth Power. We are a statewide network of young people with disabilities and experience in state systems such as the ones that presented here today. We were heavily involved in the PARS project with the Office of Mental Health, the Positive Alternatives to Restraint and Seclusion. And with that project, as Marcia mentioned, utilizes the 6 core strategies. And consumer involvement is one of the key 6 core strategies. So I just want to really encourage the Learning Collaborative and all of the cross-systems efforts, the individual efforts within the systems, to include people with disabilities, consumers, survivors, whatever they choose to be identified as, that you include self-advocacy groups, and in a substantial and meaningful way. So not only can we work with engaging peers and empowering peers and creating a sense of safety with peers, we also can help in hiring and provider practices and ensuring quality. We can also work with training workforce in that manner. And we did that with the Office of Mental Health, and I'm sure that there are a lot of groups, including Youth Power, that are willing to go out and to be a part of this movement, to really see change and to get the positive supports that we need with the respect and dignity we deserve. So I just want to really echo that and encourage that I'm really grateful for Courtney for starting this initiative, and that we were invited here today, and I really hope that people with disabilities continue to be invited to this table. We're a very important stakeholder.
Thank you. Thank you. We have a question. All right, Laura, one of our first web questions. Oh, technology is so exciting.
Oh, we have several. We have some really good questions that have come in, and the first one, I'll just do this one to follow up on what Stephanie Orlando just said. We have a question from an OMH Consumer Affairs staff member asking what peer initiatives exist to assist with reducing seclusion and restraints.
What peer initiatives exist to assist in reduction of seclusion and restraint? I do not have the answer to that question, so I turn to this room and say, is there anyone who'd like to?
Yeah, I'll introduce John Allen.
All right, John, thank you.
So I'm John Allen. I'm the Director of Consumer Affairs for the Office of Mental Health. Beginning with the PARS project, and actually predating that, predating the even SAMHSA project, nationwide consumers really were at the forefront of pushing SAMHSA as a result of Charlie Curry, who was the director and administrator at the time and had eliminated restraint and seclusion in a hospital in Philadelphia. Organizations of peers, including individuals from the Office of Mental Health and others across the nation, championed this cause and got SAMHSA to champion it and establish the 6 core strategies. Since the very beginning of this, we've had peers both at our hospitals as a peer specialist, and right now we have 144 peer specialists across all of our state-operated hospitals that are instrumental as part of not just reducing the incidents beforehand, but evaluating the treatment failures when we have to look at restraint and seclusion use following it. So how could we do a better job with de-escalation? How can we do a better job with understanding the individual's unique issues? How do we do a better job of understanding trauma? Because sometimes restraint and seclusion re-traumatizes people that have extensive trauma histories and creates a spiral that you really can't get out of unless you break that by breaking the use of forced interventions of any kind. So that's been a forefront of this. OMH has invested a lot of resources, both internally and in our public programs. We look to engage all of our providers to have peers, either as members of the workforce or as advisory groups, or preferably both, to actually look at all of our policies and practices and principles.
Thank you, Craig. Laura, do you want to do one more from the internet now, and then we'll go back to the room?
We have a question from a provider of services for people with developmental disabilities. The question is, why not also study places that have no restraints in their services?
Why not also study places that have no restraints in their services? Would anyone like to field that? Tony Alvarez from Schoharie. Let me get you a mic, Tony. Laura, can you pass, or come on up here. It's fine. I don't have to stand up here by myself. You can line up. I'd be okay with that. Come on up. And everybody can hear you.
I think that's a wonderful question and really a great idea. There's not many organizations that have managed to eliminate the use of restraints or restricted techniques in engaging people with mental illness or individuals with developmental disabilities. I think that studying an agency like that, you'll see that it does start with culture, and that it does start with the leadership, and that it does start in our agency with the board of directors. And it's a buy-in by an entire organization. So that no matter who you talk to in that organization, direct support professionals, administrators, board of directors, they're all going to say the same thing, that they wanted to engage people in a more respectful and dignified manner. So it's a great idea, and I think this learning cooperative is a wonderful opportunity for us to share the kinds of things that we do in support of the people that we serve, and we certainly would want to be a big part of that. So appreciate the question, and come out and study us in Schoharie. Thank you.
Do that. Okay, great. Regis in the back, can you get the mic back to you?
I think this is my name is Regis Obajeski from OPWDD Workforce. I think that a learning collaborative among this group is extremely valuable, and I just want to pick out a couple of themes that I heard today, and Tony just about ticked them all off already. One is leadership, and how the exercise of leadership, particularly at all the levels that Tony Alvarez just described, will induce a culture change. And so I think successful leadership strategies is one element. Another is data's role in culture change, positive culture change. All of our data there's a lot that's similar, and that there's quite a bit that's different, but I think using data. Organizational culture itself, and being fearless in trying to define what we mean by organizational culture and what we would actually do to transform positively an organization's culture. And lastly, and this is a shout out to what this gentleman said over here, that what we're doing here is really seeking service transformation. We're in a business of relationships, and service transformation is doing some very, very hard things. This is a really hard thing that we're seeking to get our arms around and change. And there's no service transformation without workforce transformation. So workforce.
Sure, hand it right over.
Hi, I'm Barbara Rothenberg from New York of Delaware County. We are fortunate to be an agency who has never used physical intervention. So we don't share the challenge that you're all going through to reduce and eliminate it. However, we can share our experiences. Everything of the key points that the presenters made absolutely is true. That is critical to what has made us successful. A couple of points I wanted to add, and a couple of people have said them, but for us, it started with a board of directors policy that prohibited physical intervention. So we always had to come up with alternative ways, because that was not an option for us for 30 years. So we have done that, and the second thing I would say is that we have a core set of values in our organization that we live and breathe, and the leadership really makes sure that all of us on all levels are interpreting it the same or living it, and that's hard work to continue that on a daily basis. And then someone else was talking about recruitment. So we recruit for those values. So we're hiring people who are going to share our culture, philosophy, and be able to live and breathe those principles.
On this side. Okay, over on this side of the room, please.
I'm Suzanne Fraser from the Chief Psychologist at Sunmount, and I'm so excited to think about a collaborative effort, because I was going to actually personally pick up the phone and call Brian, see if I could follow him around for a few weeks after his presentation about what's happening with Kirby, to see what we could learn at Sunmount. So I'm glad to hear that this is a possibility, because I was ready to do it. I was and I just want to second what Jill was saying about our effort in terms of data gathering, because I've been part of a group looking at data, especially at Sunmount, in terms of what our patterns and trends have been with some of the individuals who have shown up as needing restrictive interventions at high levels. And the data that we discovered really highlights what's happening for us in terms of a shift in the types of individuals who are now coming to Sunmount. They're a different population of individuals than I think any of us imagined we would be serving. They are individuals with significant brain injury, genetic syndromes, young women with severe trauma histories and sexual abuse histories who we are trying to serve in a facility, along with male offenders who were traditionally the focus of our treatment at that facility. So those are the sorts of folks who are really standing out in terms of needing restrictive interventions due to significant neurologically based problems, and they are coming to us in droves. Our facility, the focus of our facility, the treatment culture of our facility, really is being caught by surprise in terms of the needs of this particular population. We're set up we're a forensic facility designed to treat intellectually disabled people with criminal histories, but we were not prepared to treat significantly traumatically brain injured individuals with the scope and depth and complexity of problems that we're facing. So we now have a diverse population of women, brain injured people, psychiatrically involved people, people with sexual abuse histories and trauma histories, and we are struggling to get our staff trained and to understand how to respond within one facility to this kind of complexity of needs. So my question and my hope is that we can get some help to understand within one facility, how can we effectively address the needs of all of the individuals that we serve? What are the best practices in terms of, do we have all the women in one unit? How do we do this? What's the best way to do this? And we've tried various things, and I think we are at the beginning of establishing a new treatment culture. I think it's an exciting time for us, but I think this is partly what has happened for us. The needs of our residents really have evolved to a level that we were not prepared to deal with. So I'm ready to be a part of whatever collaborative effort
Wonderful.
is suggested here.
Back to the web, because our webcast will end in about 15 minutes, and I want to allow Courtney to have another chance to just have a closing thought, perhaps, before everyone leaves. So a few more questions, but let's see what's on the email account.
Yeah, we have several really good emails. I'll start with a comment. This is from AHRC Suffolk. Our agency has developed policy and procedures based on the 633.16 regulations, and we have ongoing collaborations with other New York State AHRCs as well as other agencies in our county. Sharing resources and collaborating is key. So thank you for that comment. I have two related emails, which is they are questions for OPWDD. Does OPWDD have any plans to start sending out a monthly restraint report similar to OCFS? It would be very helpful for agencies to see where they stand compared to agencies with a similar population. And then the second related email says, how can an agency access the overall data collected in the restrictive intervention application throughout the state to review how our agency ranks to others?
Jill, why don't you come on right up here so you have the microphone. We'll let Jill Pettinger handle that one for us.
All right. Those are good questions. The first one having to do with sharing of information about the rate of restraint. That's one of the metrics that David Bach from OCFS has been kind enough to be working with OPWDD on to try to figure out the best way for us to present that kind of information, and we're not at a point where we're able to have a level of transparency in sharing that kind of information broadly, because we're still working on assuring that we have appropriately validated, reliable data in order to inform the metrics that we're developing. But that's absolutely our long-term goal with that data. And the importance of, I think it was the second comment, around having data that's shared so that you can compare an apple to an apple, because our providers serve very different populations. So it would be critical for us, and it will also be one of the more complicated things for us to achieve, is to be able to have, this agency has this kind of population parameter, this is the type of rate of interventions, restrictive or intrusive interventions they're using, and these are the types of interventions they're using, as compared to another similar or like agency. So right now we're looking at that with our campus-based settings that are state-operated programs. Our next foray is really around, and we had a really great meeting with David earlier this week on how to really scrub our data. We have to make sure that we're getting reliable, accurate information. We have a lot of quality improvement measures that we're starting to put into play and figure out a work plan around. And I think we will, in the future, be at a point similar to OCFS where we can share that information in a much more transparent manner. But again, it will be clear what the information actually means, so that when people are comparing one to another, it's a truly meaningful or valid comparison. That has been a concern raised to me by a number of our providers, because we do have providers that have very different population parameters. They might have a residential school program that's certified as an intermediate care facility, and who they're serving, as school-age individuals looks very different than some other agency who might also be providing services to some individuals who are still of school age or young adults. So again, we have to make sure that there's understanding behind what you're comparing.
Thank you, Jill. Okay, Laura, we'll do one more, and that'll probably be it from the web, I'm afraid, from the emails. Go ahead, one more.
Has the work group discussed the variables for what necessitates restraints in each oversight agency, and if there needs to be consistency across agencies? For example, one permits only for assaultive or self-abusive behavior, and others allow for severe property damage.
Well, I think I can speak to that one even as a layperson who is just the group facilitator, and I've learned so much from all my colleagues from the various agencies. And that is, our work group is not going to do that because if we do that, we won't do anything else. And I'm not saying those aren't valid and they aren't important, and I think we all need to look at those. But we have learned from those who have gone before us. I'm smiling at Mary in the back because we've learned so much from other work groups that have gone on, and some of our members were parts of those earlier initiatives. Clarence mentioned the cycle. So we were advised clearly early on, don't spend all your time on that. You have to acknowledge it and you have to do what you can, but if we try to align things like that, we really will hinder any progress forward. And so it was a strategic decision that we didn't do that early on, and I think we're still on the right path with that, even though obviously it's a very important issue. And within our own group, we've had some interesting debates within our work group because and I won't go into that, we don't have enough time, but we do debate that from time to time just because we're all very different. All right, it's just 10 minutes before the hour now, so let me put in a couple of housekeeping items to make sure those get in, because the webcast will end and the folks on the internet will be cut off, I guess, exactly at 3 o'clock. And then if we have time for another comment, fine. And I just want to offer an opportunity, if Clarence or Courtney would like to say anything as we wrap up at the end, you're welcome to do so. But in terms of housekeeping, I want you to know that this forum is going to be archived for at least a month. So if there are, and I will have somehow, we'll get a link sent out across the 4 systems, so that if you have colleagues or folks that you think would benefit by listening to this discussion too, and you'd like to share it, you will be able to forward that to them or perhaps watch it yourself. I know I want to listen again just to hear. Again, some of the ideas, obviously, I didn't have ability to take notes on everything. So we've got this recorded, and will it be posted somewhere after a month? I'm not sure. We'll have to figure that out. There's a cost associated, and I think we're going to get a disc. So we'll work out the logistics, but we know for at least 30 days we'll be able to allow access to this discussion, and perhaps even longer. We also really want to be able to get in contact with you. Most of you who are in the room today, or if you're on the web, we were able to email you. But if you didn't get an email from one of your agencies on this, please make sure that you leave your email address at the registration table outside, because it's very important to us, obviously, that we can follow up with you and continue this discussion. I can't say right now what form this is going to take. I do feel strongly that we've heard enough positive buy-in in the room today to know that this can and should move forward, and we'll do what we can to take the next steps. So we'll want to contact you again, and that's why via email, that's how we'll do it. We haven't established the structure for this, but clearly there's interest in shared learning. We could do webinars, we could do a conference, we could do shadowing, we could network people together. There are a lot of things that we could do, and hopefully we'll be able to do in the months to come and hopefully years to come. So let's see how I'm doing on time. All right, there's still time for another question or comment from the audience. I know we have several. So we have two. Let's try to get these two in over here on this side. Either one first.
Hi, I'm Patricia Kennedy, and I'm the CEO of Springbrook. And a couple of things I want to say. Congratulations for putting this together, because this is really wonderful. And what's wonderful about it is the fact that you didn't go into the detail of definitions, because we've had many years of everybody being mired in this. And I think it was really uplifting for me to see, bypassing that, but the commonalities of all the agencies in identifying what the issues were and in many of the solutions. So I think that's awesome to have that. A couple of things, the complexity of need and best practices. Springbrook's in the position, not of Sunmount, not of Sunmount.
Patricia, too.
I know nobody ever asked me to speak louder, so I'm
today.
pleased that this is happening. Okay, the complexity of needs. Springbrook's in the same kind of position there, with accepting a lot of people out of state, a lot of people from the state developmental centers, and we really would love to see that best practice for individuals, because what we're finding is that there are a few people who we struggle with. We really do, for reducing those needs, and we're not seeing that across the board. It's not system-wide. We see some frequent flyers, if you will, for that. So we'd love to see that best practice thing happen, because I think we would all benefit from that. We're using out-of-state resources. That's number one. Workforce development is critical across the board. We are seeing the most critical time for restraints being used inappropriately are 2 times. When we have a new person coming in, critical time, but also change in staffing. And we really have to address that. And that happens frequently in our organizations. It's 70 to 80% retention. That's a critical time, workforce development. The third thing, in the learning collaborative, what I really like to see is technology taking a forefront. We're all talking about data, and I bet some of us are still using paper and pen. And we want real life time. We also want data that maybe is replicable across organizations and across provider agencies. So technology of this collaborative would be critically important for us. And then the last thing was with workforce development, and back to what Dr. Debbie, I didn't know she was Dr. Debbie, but I love it, said was with our behavior analysts. There's a shortage of behavior analysts in New York State, and a shortage willing to work with all the private providers in this group. Springbrook just started this past year a collaborative with the University of Rochester, where we support some of our teachers and bachelor level people for getting their master's and their behavior analyst certification. We'd love to have support to continue that and replicate that throughout the state.
Great. All right, one more quick comment, and then if you want to come up and close us out, that'll be great, Courtney. So there's a question or a comment back here. And it's not that we can't talk at 3:01, it's just that the webcast will probably end and those folks won't be able to hear, so go ahead.
Thank you. Hello, my name is Frank Pindak, and I'm with St. Catherine's Center for Children here in Albany, and I really support the challenge that I would put forward with the whole group is you talk about the differences in all the regulations, but the commonality that I see in all the regulations and all of the systems as trauma-informed, and having an overarching policy statement, initiative around for all agencies throughout New York State. I think about all shortly as being trauma, as being one of the criteria for health long eligibility. And I look at that and how many more children we're going to be serving in this state And if we don't have some overarching policy and position on that, I think everybody's left to their own devices and trying to figure that out. I think the Learning Collaborative can give us that opportunity to do that. Thank you.
So to wrap up before we lose the folks on the webcast, thank you to the presenters today. I was amazed at how well each of you did, and I was inspired by what you had to say. What was striking to me that we did not actually do a dry run-through or a dress rehearsal or anything of the sort, and how similar the comments were from the presenters. It was about data, it was about leadership, it was about culture, it was about the importance of the workforce, it was about having a champion, empowering people, persistence, making sure that there's safety in making these decisions. I think every single presenter touched on those themes. What we want to know now is, in going forward, how do we keep the momentum? Diane referred to perhaps seeking funding for some type of learning collaborative, which we would certainly be supportive of, and we are already thinking about how to pursue that. But what else can the state do to help your efforts? Because you really were inspirational today in your presentations to me to give me hope that this will continue in some form. So I would ask that if you have those suggestions, certainly to pass them on to us and to encourage you to keep going. There's obviously a lot of other people out there who are doing great work like you are, and to find them and to persist. So thank you for being here today, and thank you again to the organizers.
So that there ends our time together today. We're actually a minute ahead of time. So thank you again to everyone. If I don't have your contact information, please leave it out there or come and see me, because we really do want to keep this moving and want to keep in contact with you. And again, thank you all from my perspective as well. It was great to have you here. Thank you.
From the very beginning, the New York State and CSEA Partnership for Education and Training has been dedicated to improving the quality of work life for CSEA-represented New York State employees and agencies. This unique partnership has successfully increased career mobility, improved job satisfaction, and prepared for future workforce needs. It has also created a workforce that is highly skilled and committed to excellence in public service. Here are just a few examples of how the programs and services provided by the partnership are making a positive difference in the quality of work life of the workforce.
Tuition benefit has been great as far as the financial aspect. I don't receive financial aid at all, so therefore being able to use the waivers have been a very, very big help. And it's a lot to work full time, and I raised a 16-year-old totally on my own, so therefore being able to have that tuition benefit through the partnership is a huge, huge help. I've attended Broome Community College and hopefully will graduate in May with my associate's degree in criminal justice. I hope to continue on to use that when I go on for my bachelor's degree.
Some of the classes I took through the partnership are electrical advanced, plumbing and plumbing advanced. By taking the classes through the partnership, I totally understand what they're talking about with electrical terms, carpentry terms, plumbing terms. Since I was trained in the class, I'm better equipped on the actual job when I go work with the skilled people. It's an invaluable program, and I would just wish everybody would take advantage of it.
The Partnership Online program is very easy to access. You know, when I'm doing a session for the certificates, I'll download all 10 classes at once, so then as I'm going, I can just continue going through the classes at my convenience. The ease of moving in and out and the convenience of it is extremely user-friendly. I've also done some PowerPoint presentations in Excel, which I learned through the partnership as well. There's also a writing class. That was wonderful, especially with writing emails and, you know, not using slang and making sure you spell everything out and not assuming everybody knows what an acronym stands for. The punctuation and grammar, that was key.
We have that through the state and through the partnership that give you basic education skills as well as college level skills. I mean, that's awesome. I think everybody should take a class, even if you're not looking to graduate from college, but just to have it to build your own self-worth and your own needs that you want. I think everyone should take advantage of it, and especially since it's available to you through your contract. Definitely 100%.
These are just a few examples of the wide range of partnership programs and services available to CSEA-represented New York State employees. For a comprehensive listing and to find out more information about these opportunities, as well as programs and services that can be accessed directly by New York State managers and CSEA leaders, please visit our website at nyscseapartnership.org or call 1-800-253-4332.
New York State and CSEA have a proud history of working together to improve organizational effectiveness and advance the quality of work life of CSEA-represented New York State employees. This unique partnership has helped to build strong and highly productive labor management relationships between New York State managers and CSEA leaders, creating an environment that's conducive to increased organizational effectiveness, career advancement, and job satisfaction, which benefits the entire workforce as well as all agency operations. Here are just a few examples of what can be accomplished.
I'm a tremendous advocate for the Applied Skills Trade Program. The value of the training it's amazing. A labor standpoint, we always like to see our members go through it, learn it. They're learning it out of no cost to them. At the end of the 2 years, you're walking away with a certificate, you're walking away with a trade, you're walking away with something that you could use, something you've learned and something your job has given back to you. You're promoting promotion from within, so it's a big time morale booster. It's huge. The value of the Applied Skills Trade Program is tremendous for CSEA. It's tremendous for the state campuses that offer the service.
Our campus has found the Applied Skilled Trades Program as an excellent benefit and resource to our campus for a variety of reasons. We saw it as an opportunity to start planning ahead for succession planning and also be able to grow our own skilled tradespeople within the campus. I've been to a couple of the graduation ceremonies, and the pride, the sense of accomplishment that is seen by some of these folks, and regardless of their age, they're bringing in family members, their parents. It's just like going to your own kid's high school graduation. There's such a great sense of pride and accomplishment on all of them. I am just amazed that I don't see these people any longer with a co-journeyman, but now they're out there independently. I came in yesterday morning listening to one of the first gentlemen that went through the electrician program, standing at a junction box, discussing with some outside contractors exactly where it tied in, how it was tied in, what tools and equipment he'd already used to test where a fault might be or where it may have been breaking, and how it ties into what amperage in the box and things like that. And for me to know that we were part of that program was pretty huge.
There are many components of the training that I really love. One of the first things we did that I think has been operationally important for us is to have an operational agreement. In that agreement, we defined how we would function as a committee. And as new members come in, we revisit that periodically and update that, but that has provided a nice solid framework for us. I think anybody who is looking to receive the training or even considering it should jump right on it. I think that it will open up doors and it will make you understand labor management as a process. It's a give and take process. Everybody in the room is valuable and has valuable input into the product. And it can make life for the employees so much more supportive, and they have a say. Very positive experience.
Through the Quality of Work Life Grants Program, I've been able to provide equipment to the various shops and the members' break rooms. I've purchased items like microwaves, refrigerators, ice machines. The ice machines are truly valuable that the Quality of Work Life Grants Program has afforded us to purchase. The members are out on the road, they're able to have cold beverages, they're able to keep their lunches or meals refrigerated, and as an additional benefit, the ice is there to provide first aid in the event a member gets burned and needs immediate care. The employee recognition programs I've done over the years, the one was a fleet recognition program. It was a grant designed through regional labor management, so we wanted to take the opportunity to recognize those employees who are providing a valuable service and recognize them for doing their job in a safe manner.
The partnership, we got a safety grant to sponsor our flash training program. We had the excavation and trenching safety, and we had ladder and scaffolding safety, as well as lockout, tagout. The ladder and scaffolding program that we offered as well was beneficial since we have the event center now on campus. And historically, they've had to actually contract some of this out because they weren't able, our employees didn't have the knowledge and experience to be able to be trained. So we were able to put a number of people through that program. So now we can handle most of the stuff in-house.
The program was such a big hit with people wanting it and needing it because they wanted it for advancement, the future of their career.
The partnership's labor management training, I think, has set the tone for us here to help us work together, to work through some of the issues, and has helped us establish the committees we need to be able to work through them. Our safety subcommittee is a great example because we never would have created it without the labor management training from the partnership.
I know the university takes a huge advantage of the programs because it's cost effective. It's right there where what we need when we need it.
And employees really look at this as the university and CSEA looking out for their well-being because we're offering these programs for them that they normally wouldn't get that exposure to.
These are just a few examples of the wide range of partnership programs and services that New York State managers and CSEA leaders can jointly request for their work sites. For a comprehensive listing and to find out more information about these opportunities as well as programs and services that can be accessed directly by CSEA represented employees, please visit our website at nyscseapartnership.org or call 1-800-253-4332.